Welcome to the OMM-Medicine's module on idiopathic pulmonary fibrosis. Now, idiopathic pulmonary fibrosis is going to have a restrictive lung disease pattern on PFTs, so it will have a decreased FEV1, FVC, and DLCO. It will have a normal FEV1 to FVC ratio, which remember is going to be the major way we differentiate between restrictive and obstructive lung diseases, and then it will also have a high AA gradient. Now, this pattern is not specific to idiopathic pulmonary fibrosis, but it's important to remember that IPF is going to have a restrictive lung disease pattern on PFTs. Now, there are some risk factors for developing interstitial lung disease and idiopathic pulmonary fibrosis, but it's important to remember that in IPF it is indeed idiopathic, so there is not one single cause that can be identified. So some of these risk factors are going to be smoking, workplace exposures like stone, wood, dust, or other items that can be aerosolized and then breathed in and then will cause fibrotic or scarring of the lungs. Agent Orange is a historically significant and board relevant risk factor for developing interstitial lung disease and IPF, and then GERD is sometimes believed to be a risk factor for IPF as well. However, this association is still debated. So what does a typical presentation of a patient with IPF look like? Well, these patients are going to be older. They're usually over age 60, and that's because it takes a significant amount of time for scarring and fibrosis to occur in the lungs, and then it also takes a large enough area of the lungs to be affected for the patient to actually be experiencing symptoms. And these processes will take time, so typically it's going to be elderly patients who are affected. So it will typically be an elderly person who has nonspecific pulmonary findings that were gradually beginning to occur, so they will have things like dyspnea, shortness of breath, a non-productive cough, and they are classically described as having bibasilar Velcro-like crackles or Velcro-like crackles in the bottom portions of both lungs. And it's important to note that these findings are typically going to be bilateral because IPF is a systemic issue, and so it will affect both lungs, not just one specific lung. And you can also see clubbing of the fingers from hypoxia, as well as right heart failure in later stage IPF patients, because all of that fibrosis and scarring of the lungs will cause an increased afterload on the right side of the heart, and therefore the right side of the heart has to pump harder, and it can cause an eventual right-sided heart failure. So the diagnosis of IPF is typically hard to do because it is just going to be an elderly patient with nonspecific pulmonary symptoms who is presenting to your office. And there is no one specific lab that will point you to the direction of IPF. However, the best test that you can typically order to diagnose IPF is going to be a high-resolution CT scan. Now, you can't just go ahead and get a CT scan of every elderly patient who has nonspecific pulmonary symptoms, so it's important to know the actual workup of IPF, and it's typically going to start with PFTs or pulmonary function tests that, as we previously mentioned, are going to show a restrictive profile. So once a patient is found to have a restrictive profile on PFTs, we now need to rule out all other causes of restrictive lung disease before we can actually diagnose IPF. So the workup for pulmonary fibrosis is going to include things like medications. So is the patient on things like amiodarone or bleomycin or chronic nitrofurantoin or macrobid use, because all of these medications can cause pulmonary fibrosis. We also need to obtain a detailed history of the patient's work and their work exposures to things like silica or asbestos that may also be contributing to their pulmonary fibrosis. And perhaps the last and most important part of the workup of pulmonary fibrosis is going to be evaluating the patient for autoimmune conditions. And rheumatoid arthritis is one of those classic diseases that can cause pulmonary fibrosis, so can lupus, and so can many other conditions. And so a rheumatologic workup to evaluate for causes of pulmonary fibrosis is very high yield in the workup of IPF. Now, once all of these other items have been ruled out, then we are truly going down the idiopathic pulmonary fibrosis trail. And so the next step is typically imaging. And so a chest x-ray is usually going to be obtained first, and it will show increased reticular markings and fibrosis that will then prompt you to get a CT scan And it's very important to remember that a high-resolution CT scan is going to be your best diagnostic test when diagnosing idiopathic pulmonary fibrosis. Now, once you obtain a high-resolution CT scan, one of the most common and the most specific findings that you will see is something called a UIP pattern, or a usual interstitial pneumonia pattern, and that is typically a collection of findings that you will see that is very specific for IPF. Now, all of those findings are a bit out of scope for this video, but they are included in the full video listed on our website, so be sure to check that out. However, one of the most high yield and the classic finding for IPF on imaging is going to be honeycombing of the lungs. Now, it's also important to mention, because it's typically an answer choice on your board exams, but the diagnosis of IPF is typically made without a lung biopsy. It's only going to be in very rare cases where all of the workup, the labs, the imaging is non-specific that you would really consider getting a lung biopsy to diagnose IPF. Now, in terms of management of IPF, there's no cure, but you really want to provide supportive care. So these patients are typically going to need increasing amounts of supplemental oxygen. You'll want to have the patient stop smoking so that you reduce further insult or injury to the lungs. And then you will want to vaccinate for any of the pulmonary pathogens, so things like strep pneumo, the flu, pertussis, and so on. Now, there are two drugs that are commonly tested in high yield for the management of IPF, and these are going to be nintedanib and pirfenidone, and these are going to work by reducing the amount of scarring that happens after they're initiated. So they will have no true acute management of patients who have IPF, but they will slow the progression of the disease over time. And if all else fails, then a lung transplant can be considered for patients with IPF. And the final topic we'll talk about is some of the drugs you want to avoid because of increased risk of harm in the management of IPF, and they are commonly going to be listed as the answer choices on your board exam, so you want to make sure that you know that these are the wrong answer choice and do not really have any benefit in the management of IPF. Now, you can see a list of some of the drugs to avoid in IPF here. However, one I want to specifically mention is prednisone and steroids. Now, in real practice, sometimes prednisone and steroids is used for other lung issues that the patient may also have. However, for your board exams, it is important to remember that prednisone and steroids do not have a role in the management of IPF. And that brings us to the end of this module on idiopathic pulmonary fibrosis.